Good evening, everyone. My name is Gina Makwabe. I'm the consultant nephrologist and physician working with Africa Healthcare Network in Tanzania as Chief Medical Director. So I'll be chairing this session together with Dr. Frida Moore, who will be taking over the second part, the questions and the answers. Dr. Frida Moore is the consultant nephrologist working with AHN, Africa Healthcare Network in Tanzania as well. So we are excited to welcome you all. And today's topic is mastering the art of patient communication. It's a great honor to introduce to you our today's speaker, who is Dr. Arvind Conjeevaram. He's a consultant nephrologist at the Bangalore Sagar and Trustwell Hospital in Bangalore, and immediate past chair, ISN Education Social Media Team, and a member ISN South Asia Regional Board and Nephrology Education Working Group. He's a lead social media team, WCN 2017, Mexico, Avatar 2017, WCN 2018, Melbourne, Australia, WCN 2021, and Indian Journal of Transplantation. Dr. Arvind is a co-founder, Bloom Value Corporation, Hospital Optimization Software. So Dr. Arvind, it's a great honor to welcome you, and you are warmly welcome. Proceed with your today's talk.
Thank you. Thank you for that lovely introduction, and I wish to thank Dr. Lloyd Vincent and everybody at the Africa Healthcare Network for this kind invitation. So mastering the art of patient squared communication. The square is basically the patient as a noun and the patient as a verb, where we are looking to be patient with our patients. Now, I mean, doctors and patients, we are drifting apart a bit in certain areas because we are becoming smaller and smaller players in a corporate setup, and the one-to-one where you're a GP or where you have your own clinic is different when you work in corporate hospitals, where you get to see the patient in a different atmosphere. And sometimes doctors are told repeatedly that we appear arrogant, even as we ponder what's happening to that human side of care that attracted so many of us to medicine. So as you see in this cartoon, I can promise he'll see you, but I can't promise that he'll talk to you. Shouldn't be the refrain. We are actually first trained to diagnose, treat, and fix a problem, and then to comfort, palliate, and soothe the patient. But the interaction sometimes, I feel, takes a back seat. And this is usually due to the fact that we don't see the patient as a whole. We see him as a patient, him or her. We don't look at what happens to the patient outside of the hospital, or we don't give enough respect sometimes, and we need to be a bit careful about that. The conscience in that cartoon is quite important. It keeps us in a particular road that we usually travel. And as long as you maintain your conscience as you treat patients, you should do pretty well. So the communication between healthcare professionals and the patient serves two primary functions. One is to establish an ongoing relationship between the professional, the doctor, and the patient. And two, it provides an exchange of information necessary to assess a patient's health condition, implement treatment, and evaluate the effects of treatment on a patient's quality of life. So how do you go about doing this? I've actually taken three areas, and we'll be looking at these three areas in a bit more detail on where we talk to patients and where we could do patient counseling. One is the outpatient setup, where you see the patient in your consult chambers, and the patient usually walks in as an outpatient. Two, the inpatient, where the patient is admitted to the hospital and you're doing your rounds. And three, at the time of prescription or drug dispensing. Some ground rules: we should make an effort to learn the language of the region. Key phases like pain, breathing, weakness, swelling, etc. is something that you should learn. I was based in Singapore General Hospital for about 5 years in the late 90s and early 2000s. I actually took up a Mandarin class to learn about these key phrases, just to learn them so that you can put the patient at ease. Be mindful of the fact that some words in one language may mean something else in other. Since I'm speaking from the Indian context, there are many Indian words that overlap from different languages, and we need to be careful. Ideally, you'd want to use an interpreter. Also, when you explain stuff to the patient, make sure you keep it in simple terms. If you use medical jargon, that's not very good for the patient, who may not understand it at all. Simple words, simple phrases. You can use swelling instead of edema. You can use breathlessness instead of dyspnea, because those are terms that we doctors use and not the patient. So the healthcare professional should be able to understand the illness experience of the patient, perceive each patient's experience as unique, foster a more egalitarian relationship with the patients, not quite a boss-client relationship. You should have a much more equal footing relationship with the patient. Build a therapeutic alliance with the patient, because that's the only way you can meet these goals of therapy. And you should develop self-awareness of the effects of diagnosis and treatment on the day-to-day life of patients. This is something we don't do. We diagnose, we treat, but we're not aware of the effects of that diagnosis on the patient's life. Remember that patients prefer physicians with whom they've had a positive experience or who are recommended by friends and relatives. Basically, here, things move by word of mouth, and therefore it's quite important for you to have a good practice, to have a good relationship with your patients. And the way to do that is to communicate better. A physician's communication style and attention towards patient symptoms are critical to enhance the service experience. Having said that, however good you are in communicating with the patient, there are other factors that may disturb the patient. The patient's been waiting for an hour and a half to meet you, waiting time at the clinic. If you prescribe costly medications, the patient's not able to buy them. The patient may not be satisfied with the physician, and then may not recommend the physician to others. And some of these end up in a negative outcome where the patient waits for a long time, isn't able to meet the doctor, gets into miscommunication with the doctor, leads to medical violence, malpractice litigations, and all that. So the better your communication is, the lesser the violence, litigation, and so on and so forth, and the better the treatment, compliance, and health outcomes. And that's something that we should think about. Outpatient. First things first, you got to introduce yourself and your line of work. And this is something that I stress very often. What happens is, we go to see the patient, we just start with taking the history, we don't introduce ourselves, and more often the patient doesn't know who you are. In a study in the US, they found that physicians that introduce themselves only about 1 in 4 occasions. And without an introduction, it's no surprise that the patients seldom correctly identify their physician. So this is an important point, because to establish a rapport, first the physician should know your name. Ideally, you should have a label on your coat. If you don't, you should introduce yourself by name. Doesn't matter if the patient has seen you during a previous consult or a previous admission, you should ask him, do you know my name? Shall I introduce myself? And that is something that you should do every time when you see a new patient, especially as an inpatient as well. And a patient where you go to see referrals, cross referrals, something that you should do is introduce yourself and your specialty. Here's a study in the BMJ on how trainee doctors introduce themselves to patients. Only 18% mentioned their training grade, while 85% mentioned or identified themselves as a doctor. Only 22% used their professional title. Only 6% introduced themselves by name, grade, specialty, and title. 42% deliberately avoided the term trainee during introductions. And that is something that people tend to do because they don't want to appear to be a trainee when they meet patients. And this is something that is very important. What about techniques for the patient interview process in the outpatient? Ideally, you should stop talking and start listening to the patient. Get rid of distractions. especially the mobile phone, very important distraction these days. Use eye contact to show that you're listening. React to ideas rather than a person. If you're looking at the person and you think he is non-compliant or he's made a mistake in buying his medications or something, you see that as a person, you need to find out the background that led to this problem rather than attack the problem and attack the patient because of that problem. Read non-verbal messages, very important in the ladies in our context in India, and provide feedback to clarify the messages, whether the patient has been able to understand. You need to ask questions. Do you understand me? Those sort of questions, so that you know that the patient is actually listening to you. Here is a study from India. I must tell you that my practice is based in Bangalore. I'm a private practitioner. I'm a private nephrologist. I go to hospitals for my dialysis patients and transplant patients, CKD, and so on. So that is my area of expertise, and I will be talking mostly about the Indian context when I show the slides, but I have picked up a couple of slides on the African context as well, and perhaps we can discuss that during the discussion. This is an Indian study that's come out from three centers, cross-section study of 626 patients from Lucknow, Kanpur, and New Delhi. And what did they find? They found that the physicians are usually in a hurry, either due to financial pressure to generate more revenue. This could be a private care setting or a long queue of patients waiting for consultation. And this typically happens in most government-based hospitals. And especially in densely populated countries such as ours, you would expect that to happen. But this hurried approach, unfortunately, it annoys patients. They want to spend more time with you to discuss their condition. They want to ask problematic questions, and they just don't have the time. And if that happens, they're not going to recommend such physicians to their family and friends. This is a study I picked up off the internet on sub-Saharan Africa and nurse-patient interaction in this, and a scoping review that looked at quite a number of studies. And these were the countries that these studies were based in: South Africa, Ghana, Nigeria, Mali, Malawi, Tanzania, Kenya, Zimbabwe, and so on. And the second table shows you the people who are interviewed for the study. Apart from patients, caregivers, nurses, and physicians, there were pharmacists, counselors, radiologists, registrars, and so on, and health administrators. And this was the context of the study, mainly involving HIV/AIDS clinics and primary care, and a bit of maternal ICU and post-operative care. That was the care context of this study. And in most of these studies, there was, some discussion about verbal abuse, scolding, disrespect, humiliation, use of harsh language, authoritarian behaviors among nurses, and so on. And in some cases, patients had to tolerate scolding and disrespect to avoid conflicts. Some studies reported that poor patients from rural areas where there was little literacy were the most affected consumers. And some of this occurred during the night shifts. Obviously, in a smaller subset of studies, nurse communicative behaviors were reported to be supportive and friendly and empathetic. Also, care providers who implied adamantania, or respect for the personhood of patients, sharing the talk, showing the path, promoted effective patient-nurse communication. On the part of the patient's state of disease, pain, misunderstandings, unmet expectations, and so on were reported to impact on the quality of the provider-patient communication. Healthcare setting is also quite important, when you talk about communication, because if the healthcare setting has, let us say, less nurses to manage a group of patients, then you'll have work-related factors such as work overload, noise, and other problems that are going to cause or affect your patient-nurse communication. So burnout, work overload, inadequate nursing staff, and all these constraints will affect nurse-patient communication, and therefore The workload basically means that they'll have little time to communicate with it. This is a study of adult HIV patients in Kenya. And here you can see on the table in the left that most of the, uh, rankings or the scorings were pretty good. But the lowest rated item was, did they encourage you to ask questions? Did the physician encourage you to ask questions? That was rated at about 2.88. So generally, while we take the history, we just don't, at the end of the talk or at the end of a consult, I usually make it a point to ask the patient, did you understand everything? Do you have any questions for me? But when you're short of time, you tend to sort of gloss over that issue and not do that. So that's something that is quite important, as this table shows. And what is quite important is that patients who believe that their physicians engaged in a higher number of communication behaviors were more likely to attend the clinic for a follow-up, less likely to miss an appointment, and less likely to miss the antiretroviral therapy that you started. So if you communicate better with the patient, it's more likely that they're going to return for follow-up. It's more likely that they're going to take their medicines properly. It's more likely that you're going to be able to treat their illness better. That's quite important. And I'm going to bring up this study that we did, a small study of about 108 patients in the Bangalore hospital, in a hospital that I work in. And we found that there is a rampant use of proton pump inhibitors. Everybody gets proton pump inhibitors, or at least most of the patients who were admitted in the hospital. We found that about 78% of the admitted patients were on proton pump inhibitors. When you closely interact with the patient and ask him the symptom, the patient says abdominal discomfort and gas in inverted commas. So when you further interact with the patient and ask what exactly is gas, he or she turns up with the comment, oh, it's flatulence. So the proton pump inhibitor here is being used for flatulence. Quite extraordinary. The problem is, if you say gas, if the patient says gas or abdominal discomfort, the physician slaps you with a proton pump inhibitor. So it comes into the prescription and doesn't get out of it. The problem with proton pump inhibitors, it remains in your prescription. It's not an 8-week course that we give for ulcers. It just remains in the prescription. It moves on for months together, and they take it for months or years together, which is quite extraordinary, given that they have flatulence and no upper abdominal symptoms. And that's what we found and presented that in the ISN Southern Chapter conference in February 2021. So the point is, you need to really make sure that the drug that you're giving the patient is actually treating the patient's symptom. Did you correctly gauge the patient's symptom? Did you examine the patient? And so on. What about looking at the patient directly? I'm just putting this up. I'm not going to talk about the study. But this is the issue. Look at the patient before you look at the computer. Obviously, EHR has come up in a big way, electronic health records. And we tend not to look at the patient and look at the computer while entering the notes on whatever the patient tells us. EHR is not so common in the Indian setup. Of the 5 hospitals that I go to, 4 don't have EHR. We still write notes on our case sheets. But the telephone or the mobile phone is our enemy. We tend to look at it whenever we get an SMS, whenever we get a WhatsApp message, and doing that is not good when you have a patient in front of you who's in full flow with his or her history, because the patient feels that you're not paying attention, and therefore the patient feels that your communication with him is all right. So you need to be careful. Put away your electronic equipment when you're talking to the patient. What about communication with the attendants? Communicating with the attendants in the outpatient and inpatient is slightly different. It is very good, and I would tend to ask the patient to always bring an attendant, because it is quite important for the attendant to know what's happening to the patient. In this case, it could be a spouse or a son or daughter or a sibling, whoever comes in, because they need to know the progress that the patient's making. And therefore, you need to conduct conferences with the attendants, talk to them about the problem, that the patient is having. Some of the attendants may surf the net and ask for a lot of information. You need to try to satisfy their queries. I'll come to that in a moment. Very important to explain the dynamic nature of disease, because in critically ill patients, this is for inpatients, but in critically ill patients, you've got to look at explaining the criticality and the change in the criticality every time you see the patient. If a patient sits in a clinic and says he wants a second opinion, you should say, yes, please. This is quite important, because the patient will be quite happy that you said yes to a second opinion, and he may well come back to you, because if the other doctor corroborates your stand, then it is highly likely that he'll come back to you for treatment. I'm going to talk about the attendant and caregiver in a slightly different setup, and this is quite important. We sort of tend to look at them as attendants, and I brought this matter up in a set of tweets about a year ago, and this is what happens. The attendant, usually spouse or children. I have this 55-year-old CKD patient who came without her husband for a consult. He usually comes with her husband. And when I asked her, she said, oh, she bawled out and said that he died of a heart attack the previous month. He was 60 years of age and hypertensive, but he'd never bothered to go for his regular blood pressure check or an annual cardiac check. I didn't know of this and wondered, when she came out with that information that he had died, should I have asked him? After all, he was sitting beside the patient during his many visits to my OP chambers. Should I have asked him, how are you doing? Do you have any problems? Are you seeing your doctor? It's a bit difficult, I must admit, but this is something that I feel we should do, because after all, it's a captive audience as far as many things go, and why not? There was another of my patient who was on my follow-up for diabetic kidney disease for 18 years, and his son would accompany him on his OP visits. But he lived elsewhere now and wasn't accompanying him. And when he asked me whether I remembered the son, I said yes. And he said, oh, he has mild leg swelling. Could be nothing. I said, no, you better check out and get some tests done. And lo and behold, it found that the son had diabetic kidney disease with proteinuria and a serum creatinine of 1.3. You're sitting right in front of me as the patient's caregiver. So a very opportune moment where you can ask the son to screen himself for diabetes and hypertension, check your urine once a year if you have it, and so on and so forth. So should I have asked my diabetic patient to get his son screened earlier, given the fact that demographic data from my own unit, 60% of my patients are diabetic? Moving on to empathy. Empathy is a capacity to understand or feel what another being is experiencing from within the other being's frame of reference. The capacity to place yourself in another's position. But the lack of empathy is there all over, as far as I can say at present. So that tearful patient who's talked about the recent death of a loved one, the physician's next sentence shouldn't be, how's your abdominal pain? Obviously, you should sort of, grief counseling and stuff like that is what should come to your mind, rather than go directly to symptoms. But our empathy is on the downward trend, as these studies show. And this is a cross-sectional assessment of empathy among undergraduates from a medical college. This is from the Armed Forces Medical College in Pune, India. They looked at 488 patients in this study, and they found that the highest empathy, these are medical students, in their first, third, fifth, seventh, and ninth semester, the highest empathy was at entry level, and there was a significant fall by the seventh semester. Female students had significantly higher empathy levels than male students across all semesters. Now, this is an assessment of medical students from a government medical college in Calcutta in India. What did they find? They found almost the same thing. Third semester students had higher empathy scores compared to the fifth and seventh semester. Female students were more empathic than male students, and so on. So I looked at something from South Africa, and this is from the University of Stellenbosch in South Africa, measuring empathy in a group of South African undergraduate medical students. Females and students aged 25 or older had significantly higher scores for empathy rather than males and those 22 years old or less. So a bit of a difference here where the older medical student has more empathy, but females score a lot in this area. I'm going to bring up a few case scenarios to discuss with you and see how people react to this. This is a 53-year-old man seen by a cardiologist for chest pain lasting a few minutes on accustomed exercise for the past 3 weeks. The detailed history and ECG is normal. The doctor orders that. He further orders an exercise stress test that shows reversible ischemia, and then he orders an angiogram. At this time, the patient says, hang on, I'd like to get a second opinion. The cardiologist explains everything that he's done is correct, and the patient does require an angiogram. The patient says, no, I need to discuss with my family doctor of 20 years whether I need to go for this angiogram. The cardiologist is offended and says, I am the cardiologist. I am sitting in front of you. Who is the family doctor there? He's less experienced than I am. I can put the same scenario in the form of a nephrologist, and I get this many a time, that the patient sits in front of me with a creatinine of 12, 14, 16, come what may. I advise them, look, dialysis is necessary. You're quite sick. Your creatinine is high. The patient tells me, sir, my family doctor said, wait, I need to go back to him and consult, and then I'll get back to you on whether I will start dialysis. What do I do here? I write a letter to the family doctor saying that, look, this patient with the creatinine of 14 or 16 is acidotic, has acidotic breathing, is unwell, has these symptoms. I've suggested a start of dialysis, perhaps today or in the coming couple of days. Please see him and see what you can do for him. And I give the letter to the patient and ask them to go and see their GP. When a patient asks for a second opinion, I think you should say, yes, go ahead, do it. Because if you don't, you're going to lose that patient. He's going to feel offended. So why not? Get a second opinion. Here's another case. This is Bhaskar Rao, a patient in my care for that matter for 14 years, 76 years old, diabetes for the past 30 years, renal failure for 10 years, on dialysis. He gives me a call and says, look, doc, can I meet you tomorrow? I fulfilled all my responsibilities in life. I'm not sad. My children are all settled. My grandson is married. My wife, as you know, is no more. I'd like to stop my dialysis, say goodbye to this world. I'd like to talk to you about this, about how to prepare for my death. So this is quite important. This scenario of conservative care is quite important. And this is something that I'm going to come to in my later slides. But this is important. When a patient approaches you and talks about conservative care, I don't think he should be brushed off. You should sit, counsel, and see what has led him to take this decision. At some point in time, obviously, you may want to ask him to discuss with his relatives and make sure all his relatives know of his decision, something like an advanced medical directive, which also I'm going to come to, and then take a call. So this has to be a matter of discussion between the doctor and the patient and his or her relatives. And if need be, the patient can bring those relatives across, or he himself can come across to the doctor with his relatives and hammer out a sort of a way forward for conservative management. I would not take him off and say, hey, you're doing well. Why do you want to change? Why do you want to change your plan? So there is something in every consult that you need to be aware of. And here's case 3. Your patient, Mr. Roy, 65 years old, CKD stage 4, is waiting outside your room after a colonoscopy. The son comes in and says, doc, you know the report of the biopsy? It has shown cancer, but please don't tell the patient that. Tell him it's a minor infection, but do still go ahead and with the planned treatment. So how do you deal with this situation? This is something that I get very often. It could be kidney failure, the son coming and saying, please don't tell him this kidney failure. It could be a heart attack. The son comes in or the daughter says, please don't tell them. It could be cancer. That's the most common, where the patient doesn't, the son or daughter doesn't want the father or mother to know about it. And this is a slightly prickly situation, because it is the patient who is paramount. The relatives are relatives, and the relatives are relative to the problem. The patient is paramount. So it is the patient that you should look after, and it's the patient who has every right to know what's happening. So I would always advise that son to bring in, let's have a complete mutual discussion with you and your father and take it from there. I would be very disinclined to hide disease processes from a patient. What about the internet? We all have these WhatsApp forwards where I've already diagnosed myself on the internet. I've come for a second opinion. My degree of 14 years is much better than your internet knowledge of 14 hours. And this is something that we tend to get and laugh at in the WhatsApp jokes and forwards that we get about the internet savvy patient. But mind you, such patients are sometimes easy to deal with. They would have researched their disease on the net and come to you for pointers on how to take care of themselves. Yes, there are a few who would go overboard and quote sites and quote alternative treatments and so on. But by and large, we doctors should not be annoyed by this. I think it's a process where the digital age is catching up, and we should be well aware of it, and we should be able to manage that by having a frank discussion with the patient or the relative, as the case may be, who come up with internet-based cures. We can always tell them, look, these are not, these are not treatments that are in the medical literature. So I'm not going to talk about it. You can always tell them about that, but a frank discussion is always good. Let's go to the inpatient now. History taking and listening to the patient doesn't differ much. Introducing yourself, I've talked about it, mentioning your specialty. Why have you come to see the patient? Important to tell the patient that, look, I've been called because you have a change in your blood pressure, you have a change in your kidney function, and so on and so forth. Important to communicate with the patient and relatives on a daily basis. Very important to tell them about the diagnosis that you've made, the plan of action, including the management and treatment plan. Your diagnosis may change after a few days. You can as well go back to the patient and say, look, this was the diagnosis the working diagnosis we started with, but it's changed because of the investigations, and this is now my change plan of action. Where possible, and this is very important in the private setup, you need to explain costs to the patient. It need not be you yourself to explain the costs, but you can get the admin to sit with the patient and explain the finance or the admin in the hospital. It is very important for the patient to know, look, I'm going to do a kidney biopsy. This is what it's going to cost you, and so on. Very important, basically, because the patient may be an inpatient. He may go in for the surgery, and this is something that may happen time and again as an emergency. The patient is not, or the relative is not explained the cost. And mind you, in our hospital, 40 to 45% of our patients have insurance, 55% pay from their pocket. So if you don't tell them the cost before you get into the emergency surgery, and you come out and then say, this is the cost, or the surgery didn't go well, then that's not a good case scenario that you're building up. So ideally, you should explain costs at all points in time. What about the types of patients based on disease? Quite important to categorize these into high risk, rising risk, and low risk patients. And the high risk form 5% of the population, the rising risk form about 20%, and the low risk is about 70-75. Very important, basically, because this high risk that forms about 5% of the population, 40 to 50% of medical spending comes from these patients. They need more help. They have more than one illness, multiple comorbidities. ICU care and counseling will need to be done. And these are patients who are approaching criticality. So very important to talk to them and the relatives who are waiting outside and build a rapport. Even though they form just 3 to 5% of the population, they will take up at least 20 to 30% of your counseling time. You need to be able to shell out such time to these complex patients. Rising risk are even more important. If you're looking at high risk patients, they're already in the ICU. The patient's relatives already know that he's sick and therefore in the ICU. Rising risk patients are very important. Suppose you have a patient in the dialysis unit who's suddenly gone into a cardiac arrest, a patient who is in the ward who's deteriorated rapidly and needs ICU care. This category is very important because the patient and relatives now find that the patient is suddenly much sicker and he was fairly well about a day or two before. Why did he become much sicker? So this is another big chunk of patients where counseling the patients on what caused the deterioration and what is the plan of action because of that. And all that is very important. Low risk, really, they're looking for convenient access to a healthcare system, much easier to talk to them and manage them. How about counseling patients on a procedure? This is very important. First and foremost, make sure medical ethics. Is the procedure essential? If you feel it is, only then go forward. Discuss the procedure, the pros and cons of the patient, and so on, and the relatives. You need not frighten the patient into refusing the procedure. On the other hand, don't aggressively push for the procedure as well, especially if the patient is unwilling. So I have patients who come to me for a kidney biopsy who have been told the biopsy can cause bleeding. When you put that so blandly across to a patient, that becomes a bit of an issue. And I'm going to come to procedural consents in a bit. Obviously, you need to document everything. So how do I do kidney biopsy counseling? If a patient with nephrotic syndrome comes to me, and usually I'll be the third nephrologist after they've already gone to two nephrologists who have said biopsy and the patient has refused. And the patient sits in front of me and frankly says, "Sir, I've come to you because I don't want a biopsy and I want you to treat without doing a biopsy." So I tell them, look, you have nephrotic syndrome. I have 4 diagnoses in front of me, and I would like to know what the diagnosis is. So if you want to blindfold me, give me a gun and ask me to shoot at a target, I will do that. What you're asking me to do is empiric therapy. But if you want me to open my eyes, hold the gun in my hand and shoot at just one of these targets rather than blindly, I would like to do a biopsy to tell me what your disease process is. The more you explain the context of why a biopsy is needed and explain it in a manner that the patient understands, the more the patient will be willing for a procedure. Quite important to do this. Consents for a procedure are very, very important because they form the legal basis of whatever is going to happen next if you go and get into a litigation. So informed consents are very important. Usually in a hospital, the medical residents will take the consent. When I do a procedure, be it a kidney biopsy, an IJ cat, or whatever it is, I do the counseling myself. I don't allow the resident to do it. Blank consents are useless. So I would suggest you all prepare the consent document yourself. There's also a form of counseling. This is a blank consent from a hospital that I work in. I, Dr. So-and-so, have explained to the patient that all the risks of the procedure, and the patient signs this. This is extremely bland, and this is how I would put it. A kidney biopsy consent. This is actually my consent form. I've just taken a photograph and brought it up on screen. I will talk to the patient and say, these are the complications. Yes, bleeding is a complication of a kidney biopsy, but really visible blood in the urine is just 3 to 5%. Bleeding needing an operation is less than 1%, less than 0.1%. Mortality is less than 0.1%. Requiring blood transfusion less than 1%. So if you actually mention the figures and write what you're going to do in plain language to the patient and explain it, the patient is more, willing to undergo a procedure. And conversely, when the patient has, and this has happened to me, when the patient has bleeding that's led to clots, where I've had to call the urologist, put in a Foley's, do a bladder wash, the patient's relatives already know, sir, you had told us about the bleeding that was going to happen. We understand, but we hope things will get better. So you're on a, much higher pedestal because you've explained everything to the patient. This is, okay, this is a consent for dialysis. I explain everything to the patient, and on the back of every dialysis flow chart is this consent. And the consent talks about fever, line sepsis, change of lines, the possibility that you may become HBsAg or HCV positive in the future if you spend a long time in a dialysis unit, and so on. All of that is there in this. So it's good for you to write your own consents. This is the consent for IJ catheter, explaining the risk of hemothorax and pneumothorax and so on and so forth, hematoma. Very important. Let's move on to patient privacy. You need to be sure that you don't discuss things that the patient doesn't want discussed in front of his relatives. So here the cartoon says incontinence problem. So not something that you would want to discuss. So the patient is paramount. His privacy has to be protected. So whenever you're talking in front of the relatives, make sure with the patient that he is okay. I had a patient who came in some time ago who was retrovirus positive. So I said, look, your wife has to know because I'm going to have to screen her. Are you okay? And he said, okay. Do you want any of your other family members to know? He said, no. So it is the counseling that you do with the patient that is paramount, and the patient is paramount when you do all this. Moving on to prescription counseling, very important area. What we do, we just explain the dose and duration of therapy. Ideally, we don't talk about the goals of therapy, how the medication works, how effectiveness will be monitored, what are the adverse effects. We don't do all that. We just say, this is the dose, you take it. That's unfortunate because out of the 100% who prescribe the medicine, only 88% will actually fill the prescription, 76% will take the medicine, and less than 50% will actually confirm that sort of a treatment is ongoing. Lots of false assumptions. Do not assume that previous physicians have already discussed with the patient what are the medications the patient is already on. Don't assume the patients understand any of the information that you give them. You have to ask them to repeat it back and find out whether they do. Do not assume anything. Do not assume that they're able to take their medication correctly. Medication regimens are quite important. Do not assume that they don't take their medication because they are not motivated. There's several factors that lead to non-adherence, and we'll come to that in a moment. Do not assume that once patients have problems, they will contact you. They may not. So we need to really interact with them. Doctors must assess the knowledge about medication and educate those patients regarding these medications. Sometimes when I'm sitting in front of the patient and he talks about some medication that I'm not very knowledgeable about, I actually open the phone to up to date and look at that medication. So there was this tweet which said, doctors are looked down upon if you check something in a book or over the phone. They're looked down upon by the Indian public, but I really don't think so. I just tell them, look, I am going to look at the phone because that's a medicine I'm not familiar with. And if there are any side effects or drug interactions with the medicines that I am going to give you, I need to know that and I need to tell you. So I think it's acceptable practice. And that's what Amit here says as well. What are the reasons for non-adherence? Like I said, don't believe it's because the patient is not motivated. Here, 24% forgot to use or refill, 20% don't want the side effects, 17% say the drug costs too much, 14% say I didn't think I needed the drug. There's so many people who say so many things. So you need to specifically ask the patient, what happened? I didn't have the money, the drug was too costly, so on and so forth. And here you look at different disease processes that may have different reasons for non-adherence. So even disease states can influence non-adherence. And if I take the example of hypertension here, you find that 23% says forgot to use or refill. Another 20% or so say don't want the side effects. So if you look at this, it's quite important to know that each disease process, the patient behaves differently. And if you look at medication adherence in India, in hypertension, this was a survey from the Bangalore KIMS Institute here in Bangalore, and out of 608 patients, 49% were non-adherent. 78% of them said it's difficult to pay for the medication. 54% says it's difficult to get a refill on time. It's quite important. This is another study on hypertension from South India. Adherence was significantly higher among patients who were taking only one medicine, 90%. One medicine once daily, 81%, compared with individuals who are taking 4 types of medicines. You can now see that it's dropped to 21%. And as frequent as 3 to 4 times a day, that's dropped to about 20%. So the more medicines you give the patient and the more frequently you ask him to take it in a day, the lesser the adherence. And this is quite important, this table from the same study, which says even if you give the patient free medications, even then a whole lot of them will be non-adherent to the medication. Here 82% were non-adherent, even though they got the medicine free of cost. So that's something to ponder about. It's just not the cost that matters. What about medication adherence in pre-dialysis patients, chronic kidney disease? This is a study from Nigeria. And again, suboptimal adherence level, 51.4%. See the red bar here. So this 50% actually is standard, if you ask me. Tips to refill doses. There was actually a study in the UK from Bristol, where they looked at questionnaire-based, and these are all questionnaire-based survey where the patient ticks, yes, I am taking the medicine, no, I am not, to looking at urine and blood levels of medicines excreted in the urine and the blood levels of the drug. And they found that of the 50 who said yes, they were taking medicines, another 20 to 25% were actually not, because the drug levels were 0. So it's very important for us to look at, counseling patients on drug adherence, because if they don't, then you're not actually treating the disease. So simplify regimens, pill boxes, electronic applications, calendar alerts, medication doses with the daily activity tried, help from family members, and so on. So counseling the patient on the hazards of non-adherence, very, very important. 50% of patients leave their doctor's offices not knowing what they've been told. This is very important. You need to sit the patient down and tell them, I've explained most of the things. Do you understand what's happening? Please ask me any questions of any bit that you didn't understand. And if you don't, they're not going to clear their doubts. Clearing the doubts is very important. And if you don't do that, they won't. 71% of patients stated poor relationship as a cause for malpractice claims. So it's quite important to build that relationship by communicating properly. Last few slides on counseling palliative care, and this is something that I talked about in a case scenario. I have been more and more looking at palliative care as an option for dialysis patients who come in 80, 85 years old. The patient himself or herself will say, look, I've lived my life. I don't want to anymore. I don't want to do this. I don't want to start dialysis. I don't want to continue dialysis. And then the relatives come in, the son, the daughter-in-law, the son, the daughter, the son-in-law. Look, please make sure that our parent, our father, our mother lasts for a longer period of time. Do anything in your capacity to make them live longer. So this is the dichotomy that you tend to face, and it's very important to sit all these people down and counsel them together so that each understands the others. It's part of a doctor's sort of communication, counseling that helps these patients, basically because they are looking at some other form of treatment, the relatives are looking at something else, and they're being forced into treatment what they actually don't want. And that's not good, because the treatment is not going to help them when they don't want. There's a good article by my good friend, Dr. Ravindra Prabhu from KMC Manipal, who's written about end-of-life care in end-stage kidney disease. And we've gotten somehow from your loved one has a life-threatening illness and we will do whatever we can to treat it and in the meantime ensure they don't suffer, to your loved one has a life-threatening illness, we have the capacity to cure, and if we don't, we will have done something wrong. We are forcing treatment on patients who don't need it, and that's not, who don't want it sometimes, and that's not good. Grief counseling is a very important part of every doctor's day-to-day activity. Showing sensitivity to the patients and relatives, very important. Spend time with them. Just stay with them for 5 minutes if the patient has died. Most often, we tend to sort of walk away. Oh, I'm sorry, we were not able to save the patient, and we walk away. Spend time with them. I actually, put a hand on the shoulder of the son or the daughter and say, I'm really sorry. Do you want grief counseling? Do you want to speak with me? Even silence, just hang in there. Advanced medical directive is something that is quite important, not very common in our country. The Supreme Court of India, this actually refers to a patient's spoken and written instruction about future medical care and treatment. And the Supreme Court of India has given a judgment which says, yes, the patients have a right to refuse life support and so on, and then that's a living will. One of my gurus, Dr. Talwalkar, was my guru at the Bangalore hospital. In fact, I worked with him for a long time before he went on to die of HCV-related chronic liver disease. He came in one night, was admitted under my care with ascites and spontaneous bacterial peritonitis. His wife, who is the chief of anesthesia at the time in St. John's Medical College here in Bangalore, said, look, Dr. Talwalkar has already given me an advanced medical directive that he will not be put in the ICU and he will not be put on the ventilator. He was in hepatic encephalopathy. There was a good chance that we could have saved him if I'd taken him to the ICU, put him on the ventilator and treated his SBP. But he had already made an advanced medical directive, and he was only 57 years old at the time. A great man. He was a great man. Living wills and advanced medical directives are the way to go, especially for elderly people, for people with terminal illness like cancer and so on. And this is something that we should think about. Finally, I'm going to talk about code reds. This is very important. See, these code reds and cardiac arrest is something that most of the relatives and the patients see on TV. And there's one very interesting study in which the researchers watched 97 episodes of popular medical dramas and found a 75% survival rate for these fictional patients immediately after resuscitation, and 67% survival rate of that patient who gets a hospital discharge. Whereas if you take real life code reds in the hospital, the chances of survival are very low. But that's not something that the patient or relative knows. They've seen it on TV. 67% of them survive. So it's very important to explain to them, look, this is not the issue, and so on. Now, I'm speaking from the Indian perspective, and I should let you know that we did not have a set course of let us say, learning ethics or communication in our medical colleges. Most of us learned on the job. However, from 2019 onwards, the Medical Council of India, now called the National Medical Council, has set up this 8COM, which is Attitude, Ethics, and Communication. There is a PDF document available, and you can read the PDF document on the net. You can search for 8COM, and this is excellent. All medical students now going through medical colleges in India will go through this 8COM sort of modules, and that will help them. Finally, communicating with the patients also mean reporting patient outcomes and EPROMs, which is patient-reported outcome measures, which means you're now talking about what the patient feels rather than what you saw in a trial. And that's something that we did in this particular trial. We are in the process of carrying out a patient communication survey as we speak, and this is one of the forms for that. Communication with your colleagues is equally important. Word of appreciation to the nurses and dialysis technicians is quite important. Will maintain an atmosphere of harmony and goodwill. We sometimes create a toxic atmosphere because there's some mistake made and we yell at the technician or nurse. Not good. You should counsel them separately. Do not disrespect other doctors' opinion and management in front of the patients or even otherwise. Every doctor, after all, has an opinion based on what the doctor feels is happening to the patient. So you should not, at any point in time, disrespect, disregard, or joke about what the other doctor did to a patient. So my final slide, communication with patients is really an art, and we should strive to fine tune it. You should listen to your patient. You shouldn't be in a hurry. Be patient. Explain the diagnosis and plan of treatment to the patient and relatives. Mention costs. Take written and informed consents for procedures. Set up those consents yourself. Don't be harsh, arrogant, or angry just because you're in a hurry to go somewhere or you have an emergency. Be open to the idea of a second opinion if the patient so wishes. Write legibly, maintain records, document everything, whatever you said to the patient and relative. Prescribe appropriately, explain the medications to the patient, and be aware of the costs of the medications that you prescribe. Thank you.
Thank you so much, Doctor, for the presentation. Now it's the second session for the presentation where we'll allow questions, comments, discussion. If you want to talk, you can use the raise hand feature at the bottom of your screen, and then you'll be allowed to talk. You are all welcome. Okay.
Dr. Arvind, thank you for the excellent presentation. And you have reminded me all the things that I'm supposed to do as a doctor when I consult my patients. But there is one thing that maybe you could advise regarding communicating with patients who are violent. Some patients might come at the OPD and become violent. You know, as you clearly said, there might be a queue, but that patient might come inside without following the queue and will yell to the doctor. So, you know, for your experience, have you ever encountered that case, and what skills would you use to communicate to that patient?
Thankfully, I haven't experienced such a scenario, but there was a certain situation where the patients were angry because of waiting times, or situations have happened where the patient's relatives are angry because of something that's happened to the patient. And this happens all the time to most of us. The only way I would look at that situation, violence is a different sort of kettle of fish. It is extreme. Nobody is supposed to go into that area. If violence happens, I will call the security guards and ask them to handle it. But at some point in time, it would be very good to see what has led to this sort of reaction. Is it because the patient has been waiting for a long time and you've not been to the clinic in time? So whenever I come to the clinic, let us say an hour late because I've attended an emergency, I go to the waiting room and tell my patients in general, I'm extremely sorry that I have come late by an hour, but I will continue to see all of you for an extra hour today so that all of you, whatever problems you have, I will try to solve them. So generally, I would apologize to every patient who comes into the clinic and tell them, sorry, I am half an hour delayed today. I made you wait. I'm very sorry. When at the outset, you say something to a patient who's been made to wait, or whatever, you know, whatever happens to the patient in the hospital that you explain. When you apologize and then start your talk with the patient is usually pacified. Violence, unfortunately, is a different kettle of fish, and I would ask the guards to handle that. But that apart, angry patients, the best way to mollify them is to find the source and talk to the patient about the source of his anger.
Thank you. Any other one who would like to comment? Okay. If not, then I would welcome Dr. Lloyd Vincent for the remarks and closing remarks.
Although that is an exhaustive session, I don't think there's anything that was not covered, and it was really a wonderful piece. I mean, and went on, and there were so many important things that you covered, right from the cardiologist's second opinion, the need for conservative care that is very important. You know, patients that they want, not hiding facts from patients, talking to them as a whole. The question of internet diagnosis and how you deal with them. Grief counseling, I think, is a very, very important point that you mentioned. Advanced directive, that's a very important aspect as well. But it solves a lot of problems in the family if something is set up that way. And thank you for pointing out about the AdCom. I think I want to go through that and also pass it on to everybody on our channel. And I think this was a phenomenal session, Arvind. Very, very wonderfully covered and very practical, down to earth, you know, that can be implemented across the board. And so I thank you very, very much for having spent time. And I know it's very late there now. It must be now, I think it's 10:30 there, right? 10:30, past 10:30 there. So I don't want to spend more time, but extremely grateful, Arvind. Thank you so much for the wonderful session. We also, there are some requests for slides. If you can share whatever you can, we'll be very grateful, because then I can pass it across to the whole group, all of our group. And it has been a lot of learning, actually. And this is a very, very important point, which is actually completely, quite often neglected. And so many things that we actually neglect, and a talk like this actually reminds us as to, you know, for that, you know, these things are important. A lot of these aspects are very, very important. And thank you for bringing up the issue. I will never forget the advanced director, because we talked about Dr. Talwalkar. Dr. Talwalkar was the first nephrologist in the city of Bangalore. Way back in 1980, he came to Bangalore city in 1980. So when the first nephrologist came to Bangalore in 1980, and he started dialysis, and Dr. Arvind was actually with Dr. Talwalkar right from then. And they were a wonderful person, and a very concerned, you know, empathetic, you know, a doctor. I have met him for my brother at that point in time. And thank you for reminding me about him too. Extremely grateful, Arvind, for this wonderful session. And thank you so much.
Thank you. Thank Lloyd for the invite, and thanks everybody at the Africa Healthcare Network for listening to me. Thank you.
Thank you so much. Thank you.